Hi friends, today I am discussing about the topic hypertensive crisis. So hypertensive crisis, it is an umbrella term for hypertensive emergency and hypertensive urgency. So these two terms include in hypertensive crisis. So in hypertensive crisis, we will tell this in the hypertensive patient if their blood pressure is elevating more than 140 millimeter of mercury. If their diastolic BP is crossing this 140 millimeter of mercury, we will call it as a hypertensive crisis. So what we will call it as a hypertensive crisis. So we can go to the definition of hypertensive crisis. So these are the acute and severe elevation of blood pressure defines as the elevation of diastolic blood pressure. That is very important. Here in the hypertensive crisis, we will concentrate on the diastolic blood pressure rather than systolic blood pressure, with or without target organ damage. So why we are concentrating on the diastolic blood pressure? So as a heart or as a major vital organ, diastolic blood pressure is a little more important than systolic blood pressure because during diastolic time our heart coronary arteries is getting its blood circulation. That's why it is very important. Diastolic blood pressure is a little more important than systolic blood pressure. That's why here hypertensive crisis we are looking more on the diastolic BP than systolic. Or in case of the management part, we will discuss a little later. So we will concentrate on the mean arterial pressure. So next is about hypertensive emergency. When we will call it as a hypertensive crisis as a hypertensive emergency. So these types are, it is also a type of hypertensive crisis. It is characterized by acute severe elevation of blood pressure over hours to days. Here it is an important word is hours to days. Usually greater than 180 bar 110 millimeter of mercury or 200 bar 120 millimeter of mercury with associated with target organ damage. That is a key important term and important point should note down. Target organ damage is there in hypertensive emergency. But in the hypertensive urgency, similar as the blood pressure elevation, but without a target organ damage. When we are comparing hypertensive crisis, emergency, and urgency, this crisis and emergency will contribute the one-third of cases. But in case of urgency, will contribute the majority of the part. So that's why it is called this hypertensive urgency cases is very important. But it will take little more time, or it is a little chronic condition, like this it will take over days to weeks. But we already discussed in emergency, it will take within hours to days. The symptom will come and the problem will occur. But in urgency, it will take little more time or it little chronic type. So that means it is over days to weeks. So next is what is this target organ damage, or what are the organs will include in this target organ damage. So these all parts will include the vital organs of our body, including neurological, cardiovascular, renal, liver, ocular and vascular symptoms. So in which neurological already it is discussed, like cerebral infarction, hypertensive encephalopathy, intracranial or intracerebral hemorrhage or subarachnoid hemorrhage. In cardiovascular also same, like acute pulmonary edema and acute congestive heart failure or acute coronary ischemia. So these are features will come in cardiovascular symptoms. And renal, acute kidney injury or failure. Liver include liver enzyme elevated and ocular retinal damage, and vascular include eclampsia or aortic dissection. So any of this target organ damage is there. Along with that, increased or elevated blood pressure or elevated diastolic BP more than 120 or 140, we will call it as a hypertensive emergency. In case there is no target organ damage but there is an elevated blood pressure, we will call it as a hypertensive urgency. So next is we can discuss about the risk factor. What are the risk factors? So more or less this hypertensive or hypertension and other cardiovascular factors and hypertensive urgency, emergency, more or less same only the risk factors. So here also the risk factors include obesity, hypertensive patient, already a non-case of hypertension, and what may be the difference in these risk factors? Usually in the hypertensive patient, more or less we know what are the risk factors, modifiable, non-modifiable risk factors are there. So already a non-diagnosed hypertensive patient on medication or any other type of management or a lifestyle modification patient, those who are not adhered to that treatment or not following continuously or not taking the complete follow-up treatment, that time the patient may develop or may progress to this hypertensive crisis condition because they are not following, not checking their BP regularly. These all times there is more chance to get or more chance to attack or more chance to happen this hypertensive crisis. So here also we are discussing the same, like our modifiable, non-modifiable risk factors. Along with that, some additional factors are there, like a higher number of hypertensive medications. If the patient is having a hypertension, along with that some other vital organ damage or any other comorbidities, that time the patient will take, along with the hypertensive medication, or to control this hypertension they will take maybe 2 or 3 medications. Then non-adherence with hypertensive medication we already discussed, and intoxication like cocaine, amphetamine, and phencyclidine, any of this intoxication or drug abuse, withdrawal syndrome, drug to drug or food interactions, spinal cord disorders, pheochromocytoma, pregnancy, collagen vascular diseases like SLE, systemic lupus erythematosus. These all are risk factors or contributing factors for hypertensive crisis. Next, we can discuss about the pathophysiological changes. So first is acute elevation. We already told, no, already this hypertensive patients or hypertension cases only will develop the hypertensive crisis. And there is an acute elevation of blood pressure that will lead to cause loss of autoregulation of the endothelial, control of vascular tone. This endothelial structures, already we know the pathophysiological changes in the hypertension. So endothelial cells are the potent vasoconstrictors. So if there is a loss of autoregulation, that will affect, that will lead to a mechanical vascular wall stress with endothelial damage and will lead to increased vascular permeability, lead to leakage of plasma, and will lead to activation of platelet. Finally, it will lead to an initiation of coagulation cascade that will lead to the deposition of fibrin material and release of inflammatory mediators, and will have a changes or inflammatory process will active and will lead to an inappropriate vasoconstriction of the microvascular vessels, will lead to microvascular thrombosis. That is a major factor or major point, will lead to the target organ damage. Above this level, in between, we are finding that the elevated blood pressure or any other symptom, we can prevent this target organ damage. Otherwise, it will lead to a hypoperfusion or reduced blood supply to these vital organs, will lead to end organ ischemia or damage to this target organ. Already we discussed what are the target organs that damages will occur because of this pathophysiological changes. Then what may be the clinical manifestation? Clinical manifestation also we can tell it as according to the system wise. Maybe if it is a hypertensive encephalopathy or target organ damage is there, then that will lead to a sudden. Anyway, all clinical manifestation or all target organ damage, there will be a sudden elevation in the blood pressure. Along with that, headache, nausea, vomiting, seizure, confusion, stupor, coma, blood vision, transient blindness, papilledema, retinopathy, all features will be there along with this hypertensive encephalopathy. And renal insufficiency will lead to minor impairment to complete shutdown. Find or first stages, it may be a or reduced or minor problem in the kidney and will lead to a complete shutdown or renal failure. And cardiac decompensation also same, and stable angina to infarction. Unstable angina, first stage, ischemic stage, will lead to M. Maybe if it is not noticed first stages or the initial stages, we are missing that symptom, will lead to infection. Chest pain, dyspnea is very common. So these all clinical manifestation we can correlate or we can get it from the target organ damages. Next, what may be the diagnostic evaluation? So, history and physical examination indicate the severe hypertension. Once the patient admitted with any of these symptoms, we should, as a nurse or as a casualty nurse, we should check the patient vital signs as a first and foremost thing. Along with that, we should collect a history and physical examination, thorough physical examination, system-wise physical examination of that particular patient. Then blood pressure monitoring in both arms. So once we are getting a high blood pressure through our sphygmomanometer, or first should go through the palpation method to avoid the mismatch or to avoid that problems. So that time blood pressure monitoring in both arms, and should check through palpation method, then go for the auscultation method that will reduce the auscultatory gap. Next, urine toxicology, urine, blood investigation, everything. Along with that, vital signs monitoring, we should draw blood investigation, urine collection, urine investigation, everything along with that by side, we should complete it. Then serum glucose, creatinine, electrolyte values, complete blood count, liver function test, urine analysis to find out proteinuria, hematuria, proteinuria and all, to find out the signs and symptoms of eclampsia, so hematuria, to find out the kidney injury, everything we should check. Along with the chest x-ray to find out the heart condition or whether any cardiomegaly or pulmonary edema or pulmonary congestion is there. These all features will get from chest x-ray. ECG changes, hypertrophic changes we will get, or any arrhythmic changes we will get through ECG. And echocardiography, pregnancy screening to find out eclampsia features, and head and chest CT scan to find out the cerebral issues or cerebral encephalopathy or stroke. Next is we can go to the management part. Very important thing, hypertensive emergencies are the serious life-threatening condition. So it need an emergency treatment to the particular patient. It requires hospitalization, IV antihypertensive treatment. Till that patient, already a non-hypertensive patient, may need only the tablet form or oral form. But in case of an urgency or emergency, or as a hypertensive crisis patient is coming and admitting in hospital casualty, should start with an IV medication. And the major treatment should based on the mean arterial pressure, not on the systolic or diastolic. Should check the mean arterial pressure by the formula systolic BP plus 2 into diastolic divided by 3. Next, the first minute. So it is very important that to reduce the hypertension, but it is also an important the point that first minute to an hour, an expected decrease of mean arterial pressure only around 25%. Is sudden decrease in the blood pressure also may lead to hypoperfusion problems. So first hour we should reduce 25%. Next 2 to 6 hours, target goal of BP around 160 to 100 to 110 BP. Next is sudden decrease. That is, we already discussed. Sudden decrease in BP may result in hypoperfusion, will lead to the stroke or acute MI features. And the patient is stable, then plan for a gradual decrease in the BP to the normal value within 24 to 48 hours. This is the treatment hour to hour management. Then treatment decision algorithms. This is a treatment decision algorithm. If the patient already a hypertensive crisis patient, signs of end organ damage is there, yes or no, we will get. So signs are there through diagnostic evaluation like proteinuria test or the CT, MRI, everything we will get the end organ damage. If it is there, yes, means that will call it as hypertensive emergency, and this will lead to possible treatment plan for aortic dissection, stroke, preeclampsia or eclampsia management. If there is no target organ damage, we will group it as a hypertensive urgency case. So what are the common medication we can use for a hypertensive emergency patient? Usually should start with a vasodilator as sodium nitroprusside, nitroglycerin, phenol-dopam, hydrolazine or nicardipine. These are the major vasodilators available in our casualties. And adrenergic inhibitors like phentolamine, labetalol, esmolol can start, or ACE inhibitors like enalapril also we can start. And sodium nitroprusside, it is an effective drug of choice for the treatment of hypertensive emergency. And phenol-dopam is a selective dopamine receptor activator, cause renal and systemic vasodilation. Sodium nitroprusside also should give according to the doctor's orders with caution. Maybe lead to toxic effect of nitroprusside. So this is the American College of Cardiology or American Heart Association guidelines for hypertensive crisis. This is already we discussed, same only. We will group it as a hypertensive emergency or urgency. Next, we can go through the nursing management. So here we can discuss on the check BP pulse. As a nurse, we should first history and physical assessment of the patient. Within minutes, we should complete this all work. Then we should go for the hypertensive medication and hypertensive medication treatment. Regular monitoring of the hemodynamic parameter is one of the major thing. Next, confirm the rate and dose of medication. Usually it will be a continuous infusion. That's why it's very important to check the rate and rhythm, rate and dose of the medication. Then continuous ECG monitoring and chance for dysrhythmia also should check and under surveillance, and monitoring the urine output. Next is provide a complete bed rest to the patient, regular neurological assessment, because if the patient is admitted as a nursing hypertensive urgency, that time we have more important or we have very cautious about the end organ damage. If the patient is having any chance to go to a end organ damage, should find out early and should treat properly. That's why a regular monitoring of the neurological assessment, level of consciousness, pupillar reaction with size and movement of the extremity, everything should check. Then system-wise examination, patient education, and avoid the recurrence. Once it happens, should treat properly and should avoid the recurrence chances. So along with the nursing management, as a nurse, we should make a nursing care plan. What may be the nursing diagnosis? According to the patient condition, according to the patient symptoms, if the patient is having already diagnosed a stroke or encephalopathic condition, we should write as a impaired cerebral tissue perfusion, or if it is affecting cardiovascular, impaired cardiovascular tissue perfusion. Like that, we should modify according to the signs and symptom of the patient. So all the kidney means a kidney problem, we should write a system wise nursing diagnosis. We should priority should maintain, should write. If the patient only having urgency, then we can write a risk diagnosis. Maybe there is a chance risk diagnosis also we can got in the management, nursing management part. So these are the major points about hypertensive crisis. I hope everyone got little idea about hypertensive crisis. So it is once we are hearing about a hypertensive crisis, it should come into our mind that hypertensive crisis is a umbrella term for hypertensive, emergency, and urgency. It includes these both terms. And also, it is one important thing is that this two hypertensive, emergency, and urgency is based on the diastolic BP, little more important to diastolic BP than systolic BP. Once we will come to a management part, we should concentrate or we should observe the patient mean arterial pressure for giving further management and further monitoring of the patient. Continuously, we should observe the patient mean arterial BP. I hope everyone understand little about the hypertensive crisis. Thank you.